Good afternoon, everyone, and thank you very much, Michael, for the introduction and for the invite to today's session. It's great to be here with you, and as Michael says, I am a programme manager with the All Ireland Institute and chair the work that we're doing here in Northern Ireland. I start by saying, to have a palliative care policy, strategy, call it what you like. We're still working with one from 2010. As my colleagues from Northern Ireland here know, we're still working with a very small team that is no further resourced for the work they're doing. So it's all very sort of difficult at the minute. We had an ongoing palliative care inquiry there, and the results, which were to be announced by our wonderful Northern Ireland executive on the 7th of October. Well, guess what? Didn't happen. So we're still waiting for that with the bated breath. But I'm going to tell you what we're doing in the current case around education and training. So we have putting forward a piece of work, particularly around, driven by the Palliative Care and Partnership Programme, and I'll give you a bit more about that. So really what I want to do in the next 14 minutes or thereabout is condense 14 months into 14 minutes. It's a bit of a challenge, but I'll do the best I can. So the Palliative Care and Partnership Programme priorities, and these are the ones that were set out from 2023 to 2026, focusing totally on education and training. So, and you see the priority 3 is around palliative care, education and training. This was a new priority that was set in the programme planning by all the partners who are involved with the Palliative Care and Partnership, and I'll come on to giving you a wee bit of detail about that. You can see the other areas as well, but that's just 4 out of about 40 different priorities that are there. And again, all the work within the Palliative Care and Partnership Programme is underpinned by regional best practice tools and guidance. So what is this education and training framework that we're talking about? Well, as I said earlier, it's against the backdrop of a couple of policy drivers. The main one was Living Matters, Dying Matters, and I'm old enough to be around in 2010 to see that actually coming to life. The core principles there you can read for yourselves, but it is it's recognised that palliative care education should be a generic component of all pre-reg programmes across all care settings. There should be mechanisms identified to identify the education, development, support needs of staff, patients, families, carers and volunteers in place to allow the programmes to be person-centred. Again, this is rhetoric that's easy to roll off the tongue and not so easy maybe just to make happen and to operationalise. So it's a range of interprofessional education and development programmes should be available to enhance the knowledge, skills and competencies of all staff who come across patients who are in the palliative and end-of-life phase of their life with a life-limiting illness. And arrangements should be in place to provide families and carers with appropriate, relevant and accessible information and training to enable them to carry out their caring responsibilities. So there's quite a bit asked there. And, you know, this was said in 2010. We're now 15 years later. And, we are progressing. So in relation to some of the other key drivers would be the NHS National Audit of Care at the End of Life. And one of the recommendations there is that there should be work towards end-of-life care training programmes, and that should become embedded as part of induction programmes and also as part of mandatory priority training programmes in Northern Ireland. And another one of the end-of-life care service delivery from NICE guidance was that people managing services should ensure that health and social care practitioners caring for adults approaching the end of life have the training and skills to sensitively carry out a holistic needs assessment. So what is this palliative care and partnership programme that I refer to? Well, again, this was actually created in 2016. We're 9 years down the line. I have to say, and I would be remiss of me not to say, it's probably one of the best models I've had the privilege of working in my career for, along with. And it was set up in 2016. It was a hybrid of the sort of overarching. I see it as a network of a labyrinth of networks, if that makes sense. And that overarching network was driven by the then HSCB, which was the board. Now known, of course, nothing can stay. We can rename, nothing ever changes that much. No matter how much it changes, it stays the same. But the HSCB is now the strategic It's now called the Strategic Planning and Performance Group. Why, just use one word when you can use 5? So we've got the strategic Planning and Performance Group, and along with PHA, which is Public Health Agency, that was the overarching thought process for this. But remember, its roots were set in the HSCB, now sort of evolved into SPPG. So the programme board sits at that high level. It is PHA and SPPG direction, so it's the strategic driver around responsibility for palliative care. Underneath that, we have excellent these other networks that really inform, feed up, and feed the up and down and out. So we have the clinical engagement group, which is a range of all healthcare professionals who are involved in palliative care delivery, also in education as well. So a whole range of different stakeholders that really inform the sort of practical clinical side of things. We then have the regional palliative care leads. Some of you are in the audience here today, and they are based again at local level. They're in the palliative care locality boards. I'm taking you down to the bottom at the minute. So I want you to see how regionally, then we've got the middle tier, and then we've got the local delivery. It is an excellent model, I have to say, and it does result in action. Given the challenges that are against us. There's a lot of work has come out of this group simply because of the local drive and the local interest in making things happen. There in the centre then you've got the regional palliative care leads. You've got the palliative care programme Macmillan manager, who actually sends her apologies today. Diane Walker is the lead programme manager. She sends her apologies. She can't be with us today. She'd love to be here. We've got the programme support manager and the palliative care service team. So again, that is, it sounds like a lot of people, but that's 3 people basically we're talking about here. We're not talking about big numbers. And then very importantly, we have our Voices for Care service user and care reference group. And again, that sits under the umbrella of the All Ireland Institute of Hospice and Palliative Care. Out of that then is the Regional Palliative Care Education and Training Steering Group, and that's the group I chair. So that has fallen. I'm hoping to give you some sense of where the work has fallen from. We just didn't one day decide we needed to do this, but this is the drivers for it. So what are we trying to do here? Well, there's a number of work streams to be taken forward over the next 2 years. I'd say we're about 14 months into it. The sort of end game is to be in June 2026. So hopefully I may be, or some of us may be back to tell you what the finished product is. But this is what we've done so far. So phase 1, so again, these are not they don't stand alone. We straddle across and back and forward. So we have very much started and are developing the regional palliative end-of-life care training framework to support all tiers of staff currently caring for adults with palliative and end-of-life care needs across all care settings. We're identifying opportunities to provide and standardise training information for patients and carers. We didn't start at ground zero here. There's a lot of excellent work going on at local level that we are, again, scoping, bringing on board to identify the gaps and to find ways of how we may be able to make suggestions of how those gaps can be filled. We're exploring existing provision and advocating for pre-reg and post-reg palliative and end-of-life care education across professions, working very closely with our university colleagues with post-reg education delivery as well. And we're exploring and making recommendations for specialist palliative care professionals to advance their skills through education. But this is for all levels. It's not just specialist palliative care. So you'll see that when I share how we've got so far where we are with the actual framework. So how does it look any different? Well, again, hopefully you can read that for yourselves. It's quite small on the screen here, but you can read for yourselves that it's the first time that the first attempt has been made at a whole system approach across all care settings and considering pre-reg, post-reg education and training together. So it's a big undertaking. And you see by some of the figures and responses we've had, the size of the undertaking we're talking about here. It's the first time the social care or home care sector have been included, and they're a crucial workforce, as I'm sure you all appreciate and recognise, where staff are increasingly caring for people living and dying in their own homes or in care homes. And certainly that's something, again, through the Carew project that I would be involved in, and that Martina has spoken about, that you would see a lot of increased need there. We have a key focus on improving the knowledge and skills of generalist care staff, and to, I can't even read this anymore now, and to maximise and standardise the competencies that are required and the confidence and efficacy of those who are working across professionals working across care settings. And finally, we'll aim to provide a framework of existing go-to training products. So as I say, there's some brilliant stuff out there already. So the framework will point people to those go-to existing products and explore the sustainable mechanisms to provide hands-on, so work-based learning, face-to-face solutions where required, using standardised content, and we'll hope to scale and spread that through this whole co-production work that we do in the actual programme itself. So this gives you a sense of the number of sort of proportion of staff who require palliative care and end-of-life care training from our scope and exercise. So across HSE Trust, acute and community staff, including the Northern Ireland Ambulance Service, we are looking roughly, when we adjust the head count from our quarterly stats from HSE&I, 52,000 at Tier 1 and 2. GPs and staff in general practice, there's around 320 general practices in Northern Ireland, so an estimate of 2,000 to 4,000 people. Care home staff, that's the nursing and residential, and these are figures from NISC when we started this work in September 2024. There's 40,604 registered social care workers. That doesn't account for nurses working in care homes, and there's 468 registered care homes. Hospice staff, there's an estimate of 1,000, that's excluding volunteers, and registered personal assistants receiving direct payments to provide care, there's an estimate of 7,000. So in total, there's an estimate of 100,000 plus staff across care settings that require some level of palliative and end-of-life training, with at least 50% of those being employed outside the HSE&I. So a mammoth task, and we don't shy away from that. It's a huge task that we have embarked on. And let's remember as well, a lot of the staff working in care home settings, there's a very high turnover. Very fast turnover, a lot of mobility of the workforce there in care home staff. So you could have situations where maybe you're bringing people on board, giving them opportunities, and then they're moving on. But hopefully that knowledge will transfer with them, and it'll not be, it'll be time well spent. So what's the initial findings then that we have at the minute? Well, we did a scope, and these are the initial findings from the provider scope. There's a total of 694 training responses returned by providers through the scoping exercise to date. So we took out the pre and post training responses, and they were, because they're going to move into work stream C. But there's 147 responses from our colleagues in terms of pre and post reg training. The remaining returns were checked and duplicates removed. So there's a lot of cleaning, a lot of cleansing the data. So we have an internal, and that internal team of the 3 or 4 of us does all that behind the scenes between the steering group meetings. And 410 responses, and we were left with 410 responses that were mapped against the components of the draft framework, and the first and second choices were mapped against those components. So these, I'm not going to go through this, I'll let you look at that yourselves because I'm conscious of time, but hopefully you'll read that yourself and you'll see the responses, you'll see the breakdown of the responses, you'll see the domains. So basically we have 5 domains, and the work we're engaged at the minute is actually populating those domains. What are the components under each of those domains? So I'm just able to share with you today the 5 domains, and these were agreed through that steering group where we have representation from all the labyrinth of networks that sit under the Palliative Care and Partnership. And without all that engagement and that crucial help that we've got, we obviously couldn't progress to where we have. And I just would like to thank those people who have actually helped us to get so far in such a short space of time. So these were when we looked at the numbers have gone here. When we looked at them, but it's just a pie chart of the previous bar graph. So where are we here? I think this is the one I just want to get to sort of talk you through it. So at the top level, you'll see the postgrad and our breakdown at the minute in Northern Ireland in terms of the different courses that would be available. We then look at the components, and you can see there the 5 components. Under each one then, again, as I said earlier, we're not starting from ground zero. There's a lot of work going on in Northern Ireland around advanced communication skills, around bereavement care. So this, and advanced care planning. So this work will tie in to the existing work that's going in those areas. We're not reinventing wheels. We are again working alongside the great work that's going on in those areas in Northern Ireland. So the Tier 2 then are those staff that are work-based, and they will have knowledge and skills that are required in their work-based places. And Tier 1 then will be staff, and that'll be the public. We've to do more work around public and volunteers, but we see them as Tier 1, having some level of general palliative care awareness. Again, underneath, you see the pre-reg, you see the different groups who've been involved to date. So we've nursing, we've medical, we've AIIHPC, we've social workers, we've pharmacy, we've paramedics, and we've psychology to date who've engaged with us. And this is the outputs of their work. This is them telling us what they think that the workforce needs. We're not driving this from the top down, we're taking it both from the bottom up, thinking about the drivers that we have to inform this work. So again, conscious of time, that's really all I wanted to say to you at this stage. I'd like to maybe at a later date, when we have the framework finished, which should be June 26, we started in 24, maybe get an opportunity then, obviously through the All Ireland Institute, to give more detail about that. Okay? Thank you.
We have time for a question or two if anybody wants to ask Loretta a question or a comment.
Thank you very much. It was very interesting to hear your presentation just after Martina's. And I know Dr. Pereira talked about the idea that if you're moving education from Canada to Spain, are there cultural differences? But I'm not sure there's much cultural difference in Northern Ireland to the Republic of Ireland, but there are definitely health service delivery issues. But are there commonalities, that things which have been done in the north could also be done in the south? Are there ways, because there are different health services, but are there commonalities? And is there any option or opportunity to try and see how things might be done in common?
Okay. Thank you for your question, Regina. Absolutely, without doubt. There's a lot of transferability of work that's going from one side of the island to the other. Again, why reinvent the wheel? So, there will be lots of opportunities, I would say, moving forward, even currently, to look at things maybe that have been developed here in the south that we can maybe consider in the north, and vice versa.
And I think the reinvigoration of the education network is going to allow that to happen more easily. To be quite honest. Thanks, Loretta.
Okay.